This is an MRI scan of the brain in a 1-year-old child with seizures and developmental delay. One of the first things that we see is this diffuse bright signal on T2 weighted imaging in the deep juxtacortical and juxtaventricular white matter of both cerebral hemispheres. We see it in the frontal lobes. It's a little bit patchy, slightly asymmetric. We see it in the temporal lobes, occipital lobes, parietal lobes. Within that, we see in the temporal poles, we see a cystic change here on the left and suggestion of a smaller cystic change here on the right. The lateral ventricles are larger than typically expected for this age, and this is likely related to ex vacuo enlargement from decreased volume of the cerebral white matter. So all of these are signs of diffuse bilateral white matter injury and decreased white matter volume. In addition to that white matter injury, we're seeing an abnormal sulcation pattern. We're seeing shallow, narrowly spaced gyri. This is polymicrogyria. Now, it's a little more challenging to see in this case where there's, first of all, myelination in a 1-year-old is not as much as it was in the other cases. Secondly, there's diffuse white matter injury. So that makes seeing the polymicrogyria a little bit more challenging. But if we use all the images we have available to us, we can see here on the sagittal T1 weighted image along the inferior aspect of the inferior frontal gyrus, we can see some narrowly spaced gyri. This is polymicrogyria. Then one additional thing that we see, in addition to the polymicrogyria and diffuse white matter injury, white matter volume loss, and temporal pole cystic changes, is on the susceptibility weighted image, we're seeing areas of susceptibility hypointensity in the periventricular white matter here in the right inferior parietal lobe and here in the left occipital lobe. These are likely related to dystrophic mineralization. Collectively, these findings are very suggestive of in utero cytomegalovirus infection. One of the other clinical presentations of children with in utero cytomegalovirus infection is congenital sensory neural hearing loss. Hi, my name is Asim Chowdhury. I'm a pediatric neuroradiologist from Le Bonheur Children's Hospital and the University of Tennessee Health Science Center in Memphis, Tennessee. We're going to be discussing in this series aspects of pediatric neuroradiology related to supratentorial malformations and malformations of cortical development. This is an MRI scan of the brain in a 5-year-old child with seizures. And we start by looking at the T2 weighted image, and we can see an slightly atypical appearance of the ventricular system. The right lateral ventricle is a little bit larger than the left lateral ventricle. But the bigger thing we see is an asymmetry in the sulcation. The normal sulcation pattern we can see here in the frontal poles, where we can see the normal undulation of these gyri. We have the cortical gray matter at the periphery, and this darker area subjacent to that is the white matter. This is a normal sulcation pattern. If we go over here to the right middle frontal gyrus, for instance, we can see very shallow, narrowly spaced gyri. We see a similar appearance over here on the left. And then if I go to the sagittal T1 weighted image, it becomes even more evident that compared to the normal sulcation pattern here in the temporal lobe, we have very shallow, narrowly spaced gyri. And this is what's called polymicrogyria, poly, many, micro, small gyri. We have polymicrogyria here in the inferior frontal gyrus. This is along the Sylvian fissure, so this falls under the heading of Perisylvian Polymicrogyria. But that term is not uniquely descriptive of a given disease pattern, because if we see in this individual, we can see some abnormality in the superior aspect of the superior temporal gyrus. And if we go superiorly, I'm going to go to an axial thin section T1 weighted image. We have polymicrogyria in the bilateral middle frontal gyri. Here's the left middle frontal gyrus, the right middle frontal gyrus, extending posteriorly past the central sulcus, involving the right inferior parietal lobule right here, and portions of the right parietal lobe. So this is a case of a bilateral, relatively symmetric polymicrogyria involving the perisylvian white matter as well as additional portions of both parietal and frontal lobes. This is an MRI scan of the brain in a 2-year-old child with developmental delay, and we can already see there is an abnormal sulcation pattern along the insular cortex I'm going to look at the sagittal images, the sagittal T1 weighted imaging, and we can see shallow, narrowly spaced gyri and subtle blurring of the gray-white differentiation in that location. This is polymicrogyria. This here is the Sylvian fissure. We're seeing polymicrogyria along the superior margin of the Sylvian fissure in the inferior frontal gyrus and inferior parietal lobule, as well as portions of the superior temporal gyrus. So this is Perisylvian Polymicrogyria without involvement and a relatively normal sulcation pattern in the frontal lobes otherwise, and the remainder of the temporal lobes. So the predominant involvement is bilaterally in the insular cortex that we see here, as well as the frontal and parietal operculum and the temporal operculum. This is an MRI scan of the brain in a 1-year-old child with seizures and developmental delay. One of the first things that we see is this diffuse bright signal on T2 weighted imaging in the deep juxtacortical and juxtaventricular white matter of both cerebral hemispheres. We see it in the frontal lobes. It's a little bit patchy, slightly asymmetric. We see it in the temporal lobes, occipital lobes, parietal lobes. Within that, we see in the temporal poles, we see a cystic change here on the left and suggestion of a smaller cystic change here on the right. The lateral ventricles are larger than typically expected for this age, and this is likely related to ex vacuo enlargement from decreased volume of the cerebral white matter. So all of these are signs of diffuse bilateral white matter injury and decreased white matter volume. In addition to that white matter injury, we're seeing an abnormal sulcation pattern. We're seeing shallow, narrowly spaced gyri. This is polymicrogyria. Now, it's a little more challenging to see in this case where there's, first of all, myelination in a 1-year-old is not as much as it was in the other cases. Secondly, there's diffuse white matter injury. So that makes seeing the polymicrogyria a little bit more challenging. But if we use all the images we have available to us, we can see here on this sagittal T1 weighted image along the inferior aspect of the inferior frontal gyrus, we can see some narrowly spaced gyri. This is polymicrogyria. Then one additional thing that we see, in addition to the polymicrogyria and diffuse white matter injury, white matter volume loss, and temporal pole cystic changes, is on this susceptibility weighted image, we're seeing areas of susceptibility hypointensity in the periventricular white matter here in the right inferior parietal lobe, and here in the left occipital lobe. These are likely related to dystrophic mineralization. Collectively, these findings are very suggestive of in utero cytomegalovirus infection. One of the other clinical presentations of children with in utero cytomegalovirus infection is congenital sensorineural hearing loss. This is an MRI of the brain in a child with seizures and developmental delay, and we can see a severe paucity of sulcation. The brain surface is relatively featureless. We see a very rudimentary Sylvian fissure here on the right, and a shallow version of a similar structure here on the left. So otherwise, it is very featureless. We see a little bit of, in this parasagittal aspect of the frontal lobes, we see the anterior aspect of the cingulate gyrus. If we go here to the sagittal image, we see the parieto-occipital fissure, we see the calcarine sulcus, but otherwise, we're seeing very few sulcations within the cuneus of the occipital lobe, as well as the lingual gyrus of the occipital lobe. If we go a little bit off to the side, we're also seeing minimal sulcation, very featureless brain. In addition to the surface findings of a relatively featureless brain, we're seeing a very thickened, what looks like cortex, but not all of this is really cortex. If we look at an image here, we can see the gray matter at the periphery, but all of this is actually an intervening area. Here in the right occipital lobe, we can see this is the cortex. These little areas where it looks slightly bright is actually white matter. It is what's called the cell sparse zone. And then beneath that is an additional band of gray matter. That band of gray matter follows the surface of the brain throughout both cerebral hemispheres. This deeper gray matter that's in a band-like configuration is not in the normal location, so it's called heterotopic gray matter. This pattern of heterotopic gray matter is called band heterotopia. The smooth surface of the brain is known as Lissencephaly. Lissencephaly, especially the more severe forms, is often associated with a band-type heterotopia. Band heterotopia is an abnormality of neuronal migration. We can see other abnormalities here, that there's a severe loss of the cerebral white matter volume. Overall, the brain doesn't have a lot of the landmarks we're used to seeing. The lateral ventricles have a slightly dysmorphic appearance due to the abnormal configuration of the surrounding white matter. And we can see the cerebellum looks closer to normal than the cerebral hemispheres. The cerebellar volume is a little bit lower than usually seen, but compared to the cerebral hemispheres, they're relatively preserved. And this is an abnormality known as Lissencephaly with band-type heterotopia. This is an MRI of the brain in a 9-year-old child with developmental delay. And on the axial T2-weighted image, we see several things. First of all, there's a decreased volume of the cerebral white matter and corresponding enlargement of the lateral ventricles. When we go from the lateral ventricles out towards the periphery, we can see there's what appears to be white matter here, and then something that looks like gray matter. In between that, we see these little bright areas. This is known as the cell-sparse zone, and overlying that is the cortex. This here is an appearance of Lissencephaly with paucity of sulcation with underlying band heterotopia. Now, in contrast to the first case we saw of Lissencephaly with band-type heterotopia, in this individual here, we don't have band heterotopia in the frontal lobes, and we have a more normal sulcation pattern in the frontal lobes. So this is a posterior predominant involvement of the Lissencephaly with band-type heterotopia. And it's noted that a posterior predominant involvement of this disease process oftentimes is related to an abnormality in the LIS1 gene. So that is the type of thing that can actually be put in a report to possibly help guide genetic testing. And the genetic testing has implications both for the patient as well as for the family and for siblings. If I look on the sagittal image, we can see the parieto-occipital sulcus, calcarine fissure, the cuneus, very, very rudimentary sulcation. We're not seeing a lot of surface features. The lingual gyrus, very few surface features. The precuneus of the parietal lobe, similarly, we're seeing a paucity of sulcation, we're seeing the overlying gray matter, we're seeing the cell-sparse zone, and we're seeing this band-type heterotopia. What I'm going to do is I'm going to show this on this T1-weighted image, and I'm going to zoom here. Here we can see there's a very featureless surface to the brain. Between the surface and this line is the gray matter. Subjacent to the gray matter is a cell-sparse zone, and beneath that is the band-type gray matter heterotopia. So we can see there's all the features of Lissencephaly with band-type heterotopia seen here. We see the featureless surface, we see the cell-sparse zone, we see the band-type heterotopia subjacent to this. As mentioned in this individual, we do not see this anteriorly. This was not seen anteriorly here. There's relative sparing. That posterior predominant involvement of Lissencephaly with band-type heterotopia is often associated with abnormalities in the LIS1 gene. This is an MRI of the brain in a 1-week-old child that had an in utero abnormality that wanted to be further characterized. One of the first things we see is this very, very featureless surface sulcation pattern to the brain. We're seeing a rudimentary sylvian fissure on both sides. At most, it looks sort of like a large figure 8, but we're not seeing any other major sulci. Within that, we're seeing enlargement of both lateral ventricles, more pronounced posteriorly. On the brain, we're actually seeing something that we saw on the other cases. We saw the peripheral cortex. We see a cell-sparse zone that's bright on T2-weighted imaging. And then we see what is a band of gray matter-like substance called gray matter heterotopia. So this is a very severe case of Lissencephaly with band-type heterotopia. At this point, instead of just Lissencephaly, which means smooth brain, it can also be referred to as Agyria, because there's essentially no gyri. The coronal image here also shows, you can see the temporal lobe is just one single curve on the periphery with no surface undulations. You see that subtle curvature for this concavity for the Sylvian fissure, and we're not seeing any sulcation whatsoever in the frontal lobes. This is a fairly severe appearance. The patient beforehand had a head ultrasound, which also showed a very featureless temporal lobe, very featureless parasagittal cortex here in the frontal lobes. The one thing to be aware of, though, is to be careful on ultrasound especially to not overcall Lissencephaly in the setting of severe prematurity. The sulcation pattern that looks abnormal in a term infant could be normal at 32 weeks or 28 weeks. So in a premature infant where some of the brain development has not yet taken place, we have to be careful not to overcall Lissencephaly. That said, this severe abnormality is definitely a true Lissencephaly. The MRI confirms the self-sparse zone and the band-type heterotopia. So this is a severe case of Lissencephaly with band-type heterotopia with an agyric pattern. This is an MRI performed of a woman who is pregnant, and so the MRI is focused on the fetus itself, in particular the brain. There was questions on the ultrasound about the size of the brain and the features of the brain, and so this MRI was performed. And we can see here posteriorly, we can see some sulcation. It's difficult to see in fine detail in a fetal MRI because of the small size, but you can see there's some sulcation and some different substructures. But if we go to the frontal lobes, in particular the frontal poles, this is very featureless. Same with on the left side. So both sides we're not seeing much. If we go to the sagittal view, we're seeing a very featureless frontal lobe. Overall, the brain size is smaller than expected. If you look at the craniofacial ratio, the head does not, and the brain does not project up significantly relative to the size of the face. Here is the nasal bone down to the lower lips and the chin. So we have a smaller than expected brain with a paucity of sulcation anteriorly. The lack of sulcation prior to term infancy is very challenging to assess normal from abnormal. But this infant is, I believe, nearly 30 weeks gestation, at which time you should have more sulcation than this anteriorly. Also, there shouldn't be such an asymmetry between the frontal lobes where we're seeing very little sulcation and posteriorly where we're seeing much more. And this right here is highly suggestive of an anterior predominant Lissencephaly spectrum disorder. This was confirmed on postnatal imaging, and it is noted that an anterior predominant Lissencephaly oftentimes is related to an abnormality in the DCX gene, DCX. That's in contrast to the posterior predominant Lissencephaly, which is related to abnormalities of the LIS1 gene. So this is something that can be done where on the imaging you can at least give some hints at what genetic defects might be causing the structural findings, which can help guide the geneticists, the maternal fetal medicine doctors, the neonatologists, and other and neurologists on what genetic tests to order, because there's so many possible genes out there. But for Lissencephaly, or relatively featureless parts of the brain, anterior predominant Lissencephaly, you think DCX gene. Posterior predominant Lissencephaly, you think the LIS1 gene. This is an MRI of the brain in a 2.5-year-old child with developmental delay. On the T2-weighted image, we're seeing the sulcation pattern. We're seeing more gyri than in some of the more recent cases, but it's still not a normal sulcation pattern. We're seeing a paucity of sulcation, and On this sagittal T1 weighted image, we can also see, while we see gyri throughout both cerebral hemispheres, anterior and posterior, it's still not the same degree of sulcation like we normally see. Now, the one thing also that we can see well on the T1 weighted image is we see the nice gray matter, and beneath that we see the white matter. There's no band type heterotopia. So this is a diffuse mild Lissencephaly spectrum disorder involving both cerebral hemispheres, anterior and posteriorly, without band type heterotopia. This is an MRI of the brain in a newborn, in a child who had an abnormal fetal ultrasound. We can see right away that there's an abnormal configuration of the ventricular system on this T2 weighted image. So there's a monoventricle. There's no two separate lateral ventricles. There's one big, relatively amorphous ventricle. Additionally, we don't have any intrahemispheric fissure. The cortex, which is relatively featureless, of one cerebral hemisphere goes all the way over to the contralateral side. We see likely what is a single anterior cerebral artery. Additionally, we see fusion of both thalami. Now, the cerebral hemispheres are part of the brain called the telencephalon. The thalami are part of the brain called the diencephalon. Those are the parts of the brain in a 5-part mature brain. But developmentally in a 3-part brain, the diencephalon and telencephalon come from what's called the prosencephalon. So an abnormality in the prosencephalon, which we see here with the telencephalic component and the diencephalic component, is a prosencephalic abnormality. This is referred to as holoprosencephaly. Holo meaning one, prosencephalon. So there's one prosencephalon. The two sides of the brain did not split apart from one another. This is a very severe case of holoprosencephaly called Alobar Holoprosencephaly. Now, the posterior fossa contents can be closer to normal, but the cerebral hemispheres are very abnormal. There's featureless cortex, decreased white matter volume, monoventricle, abnormality of the deep gray nuclei. Additionally, we notice the globes are too close together. The globes, as a rule of thumb, you should be able to put about one globe in between the two of them. This is much less than that. So this is signs of hypotelorism, which is associated with craniofacial abnormalities, and holoprosencephaly is often associated with craniofacial and other midline abnormalities. We can see in this individual here on this sagittal image, here's the pons, here's the medulla oblongata, here's the midbrain. Going forward, we have a very amorphous conglomeration. We do not see discrete mammillary bodies. We do not see a discrete hypothalamus. So all of this is very abnormal. This bright area here is likely a neurohypophyseal area of T1 shortening, but it's not within the cella turcica itself. So it is not uncommon for children with a holoprosencephaly to have other midline defects. Pituitary abnormalities, which goes along with endocrine dysfunction, craniofacial abnormalities, including clefts, as well as bony abnormalities of the spine and other things. So this is a very severe holoprosencephaly spectrum disorder known as Alobar Holoprosencephaly. This is an ultrasound of the head in a newborn infant that had an abnormal fetal ultrasound. The ultrasound was performed through the anterior fontanelle, and this is in the coronal plane. We can see sulcation here in the location where you'd expect the anterior aspect of the intrahemispheric fissure. You can actually see gray matter and sulcation going across the midline. And so this is not normal. Normally, the two cerebral hemispheres do not have any sulcation that crosses over. At a later age, a CT scan of the head was performed. This shows an abnormal ventricular system. There's no septum pellucidum. The lateral ventricles posteriorly are larger than you would normally expect. And we're not seeing the anterior horns of the lateral ventricles very well. We're not seeing good delineation between the two thalami. And we're also seeing gray matter continuity across the expected location of the intrahemispheric fissure anteriorly. Now, posteriorly, we are seeing a falx cerebri. Anteriorly, we do not see a falx cerebri. So this is an individual that has elements of a holoprosencephaly spectrum disorder, but posteriorly, we look like we have two different cerebral hemispheres, unlike the case of the Alobar holoprosencephaly that we saw. but anteriorly we're seeing signs of a single cerebral hemisphere. An MRI is performed showing some fusion of the thalami, which is a diencephalic structure, and anterior midline continuity across the expected location of the interhemispheric fissure anteriorly. This corresponds with the appearance on the ultrasound. We also see a single or azygous anterior cerebral artery right here. Posteriorly, we see a falx cerebri, and we see two separate occipital lobes. So this patient has some features of holoprosencephaly, but it's not as severe as the Alobar Holoprosencephaly that we saw. If we look at this sagittal T1 weighted image, posteriorly we see a normal appearing cerebellar vermis, relatively normal appearing brainstem. We can see normal sulcation in the precuneus of the parietal lobe as well as in the occipital lobes here. We're seeing the posterior portion of the corpus callosum, the posterior body, isthmus, and splenium. Anteriorly, we lose the corpus callosum. Anteriorly, we also have, along the interhemispheric fissure, we have actually gray matter, where there normally should just be white matter. So this is a patient with, posteriorly, it looks like the two cerebral hemispheres separated from one another. Anteriorly, they did not. And this is a holoprosencephaly spectrum disorder referred to as Semilobar Holoprosencephaly. This is an MRI of the brain in a newborn that had an abnormal fetal ultrasound. And axial T2 weighted image shows a couple of things. First of all, we see this anterior sloping of the frontal bones that goes up to the midline. And midline, well, we don't get a great view of bone on MR compared to CT. It looks like there's actually bone continuity between the two frontal bones, whereas at this young of an age, the metopic suture should be there. So this raises possibility of metopic suture craniosynostosis, which can result in a skull configuration known as trigonocephaly. Now, if we go down further on this coronal image, we can see anteriorly across the interhemispheric fissure, we have gray matter continuity. We have cortex going all the way across and white matter going across beneath that. That's unrelated to the corpus callosum. So that's not normal. The two cerebral hemispheres should be separate from one another other than commissural fibers, such as the corpus callosum and anterior commissure. So this gray matter continuity is abnormal. We also have a slightly dysmorphic ventricular system, but much less so than in the case of semilobar holoprosencephaly that we saw, and much closer to normal than the case of alobar holoprosencephaly, which we saw. There's some fusion of the thalami, but the thalami are otherwise separately formed. This almost looks like a large massa intermedia. So this patient has a very mild holoprosencephaly spectrum disorder. It is truly speaking a holoprosencephaly spectrum disorder because we have the gray matter of the cortex here, which is a part of the telencephalon, and the thalamic abnormality, which is a part of the diencephalon. But this is a milder end of the spectrum of the holoprosencephaly spectrum disorders, known as lobar holoprosencephaly. We have an interhemispheric fissure. We still have an azygous anterior cerebral artery here. We have midline continuity. Anteriorly, the falx cerebri is not well developed. Posteriorly, it is developed. So it has some features more normal than the semilobar holoprosencephaly, but it has definitely abnormalities that differentiate this from a normal appearing brain from this age. This is an MRI of the brain in a 13-year-old with developmental delay as well as some seizures. And there's several things that we see. First of all, in this image, we do not see a septum pellucidum. If we go up, we actually see there's midline continuity of gray matter across the anterior aspect of the interhemispheric fissure. Now, if we go down lower, we see two separate thalami. So remember we talked in the holoprosencephaly spectrum disorder that the thalami are a part of the diencephalon, whereas the cerebral hemispheres are a part of the telencephalon. So together, the diencephalon and telencephalon are the prosencephalon. Well, we don't have a prosencephalic abnormality because the diencephalon is normal. So this is an isolated telencephalic abnormality. Well, what else do we see that's abnormal? Well, in this sagittal image, we see segmental dysgenesis of the mid portion of the corpus callosum. There's some gray matter heterotopia here, abnormal gray matter in this location. And if we go to the side, there's almost vertical extension of the sylvian fissures here. And this right here is an abnormality that's known as syntelencephaly, S-Y-N, meaning like synapse coming together, of the telencephalon. It's a milder version even of a holoprosencephaly spectrum disorder. We still see what's an azygous or unpaired anterior cerebral artery and midline continuity of the telencephalon, but we're not seeing all the other features that would make this a true prosencephalic abnormality. So syntelencephaly is an even milder hemispheric cleavage abnormality than lobar holoprosencephaly. This is an MRI of the brain in a 3.5-year-old child with some vision abnormalities. One of the first things we notice is absence of the septum pellucidum. We see the 2 lateral ventricles are normal in size, but there's no intervening septal leaflets. As we scroll through the brain overall, the sulcation pattern looks normal, the myelination pattern looks appropriate for age. So other than the absence of the septum pellucidum, the brain itself looks fairly normal. If we go to the sagittal T1 weighted image and we zoom in on the suprasellar region, we can see the optic chiasm is smaller than we typically expect. This is the pituitary infundibulum. Here's the adenohypophysis. This area of T1 shortening is the neurohypophysis. Mammillary bodies. Here's the third ventricle. We have the infundibular recess and the chiasmatic recess of the third ventricle. But the optic chiasm is smaller than it typically should be. Well, let's look at the optic nerves otherwise. So on this coronal image, we're going to zoom in and we can barely see the optic nerves. The bright around it is CSF within the optic nerve sheath, and the optic nerves themselves are small. On this coronal image, we can see the optic nerves are small. We will zoom in, and we can see the optic nerves are small throughout their course in the orbit. Going back here to the optic chiasm, that's the pituitary infundibulum coming down from there. So we can follow the optic nerve bilaterally is small. And the axial image confirms you can see a very thin optic nerve, which is the T2 hypointense structure within the central aspect of the optic nerve sheath. If you remember, the optic nerve is, truly speaking, a part of the central nervous system. It's surrounded by CSF and dura. The dura is the optic nerve sheath. So this patient has bilateral optic nerve hypoplasia, also hypoplasia of the optic chiasm, and absence of the septum pellucidum. That spectrum of abnormalities is known as Septo-Optic Dysplasia. This is an MRI of the brain in a 6-year-old child who has vision abnormalities, developmental delay, and also seizure. The first thing we see is absence of the septum pellucidum, and if we look on this sagittal image, we see the optic chiasm is smaller than typically expected. I'm going to zoom in, and you can see the optic chiasm here on the sagittal T2 weighted image. Here's the pituitary infundibulum, the pituitary gland, mammillary body, floor of the third ventricle. So in addition to a smaller than expected appearance of the optic chiasm, so smaller than expected appearance of the optic nerves, as well as absence of the septum pellucidum, are the features of septo-optic dysplasia. Now, there's some variations on septo-optic dysplasia. This patient has more than just those key findings. They also have this abnormality in the contour of the lateral margin of the right lateral ventricle, which goes out to the periphery. Now, if we look at this on a coronal image, we can see this cleft between the lateral ventricle all the way out to the periphery is lined by gray matter. This line by gray matter, also on this side, that is what's called a schizencephalic cleft. This is an open-lipped schizencephalic cleft in the setting of septo-optic dysplasia. Additionally, the margins of this is not normal gray matter. It's actually polymicrogyria within this gray matter. So this individual has polymicrogyria lining a open-lipped schizencephalic cleft in the setting of septo-optic dysplasia. This is an MRI of the brain in a 14-year-old with short stature, also with some vision abnormalities. On the axial T2 weighted image, we see the absence of the septum pellucidum. The lateral ventricles otherwise look fairly normal, but there's no intervening septum pellucidum. The brain otherwise looks relatively normal, other than in the anterior aspect of the left middle cranial fossa, we have an arachnoid cyst, which is a normal variant. If we look on this coronal image, we see very small optic nerves in the posterior orbital segment of the optic nerves. with surrounding prominence of the CSF in the optic nerve sheath. Those are signs of optic nerve hypoplasia. If we look at the sagittal T1 weighted image, we see a very small optic chiasm. So a small optic chiasm, small optic nerves, and absence of the septum pellucidum are the features of septo-optic dysplasia. But this individual has one other finding that can be associated with septo-optic dysplasia that we need to be aware of. If we look here, this is the sella turcica, and this here is the adenohypophysis. Normally, posterior to the adenohypophysis, there's a neurohypophyseal area of T1 shortening, or the posterior pituitary bright spot. We don't see a posterior pituitary bright spot. We also don't see a pituitary infundibulum. But what we do see is at the expected location of the infundibular recess of the third ventricle, we see a bright globular area here. This is an ectopic neurohypophysis. The neurohypophysis, which normally migrates down from the hypothalamus down along with the development of the pituitary infundibulum to end up along the posterior aspect of the pituitary gland, never migrated. Interestingly, this is an abnormality that, from an endocrinologic standpoint, usually has little to no posterior pituitary dysfunction. The dysfunction is actually related to the anterior pituitary because, given the lack of migration of the posterior pituitary down to the sella turcica, the pituitary infundibulum doesn't form, and when the pituitary infundibulum doesn't form, the hypothalamic hypophyseal portal venous system does not form, and so therefore the releasing hormones from the hypothalamus never reach the pituitary gland, so the pituitary gland is understimulated, and therefore you have adenohypophyseal dysfunction, which can manifest with things such as short stature and abnormalities with puberty. This is an MRI of the brain in an 11-month-old child with small optic nerves that were identified on ophthalmologic examination. On this coronal image, we see absence of the septum pellucidum and otherwise relatively normal appearing lateral ventricles. If we go forward, we see a smaller than expected optic chiasm and smaller than expected optic nerves. So those are the features that we've described with septo-optic dysplasia: absence of the septum pellucidum and hypoplasia of the optic pathway. Now, there's additional features that you can sometimes see. In this patient, we see a focal contour irregularity along the lateral margin of the body of the right lateral ventricle, and that there's this gray matter-lined cleft that goes out to the periphery. And this is a schizencephalic cleft. This is a very subtle schizencephalic cleft. It's nearly what's called a closed lip schizencephaly. Now, a closed lip schizencephaly is where the gray matter margins are up upon one another, and an open lip is where they're widely apart. Now, from my perspective, it's parsing terms to debate whether this is open-lipped or closed-lip schizencephaly, because either way, the parenchymal defect is relatively small, and so we're missing a small amount of brain. So whether you call this a closed-lip schizencephaly or a very narrow open-lip schizencephaly likely has no clinical differentiating features. The issue is that there's not a large gap where there's brain parenchyma missing. So this is a patient with septo-optic dysplasia and a closed lip versus a narrow open lip schizencephalic cleft. This is an MRI scan in an 11-year-old with developmental delay and seizures. As we scroll through, we encounter a number of abnormalities. First, on this sagittal T1 weighted image, we see a thickened splenium and isthmus of the corpus callosum, and we don't see the anterior portions of the corpus callosum. We don't see most of the body, the genu, or the rostrum of the corpus callosum. We see a somewhat thickened anterior commissure. As we scroll up, we see a closed-lip schizencephalic cleft going to the lateral margin of the posterior body of the right lateral ventricle, lined by polymicrogyria. You can see here there are areas of polymicrogyria adjacent to this closed-lip schizencephalic cleft. Here, adjacent to the frontal horns of the lateral ventricles, we're seeing extra areas of gray matter. This is called gray matter heterotopia. In the left cerebral hemisphere, almost corresponding to the same location as this closed-lip schizencephalic cleft, we're seeing something that looks very similar. We're seeing a deep sulcus, but the sulcus doesn't go all the way to the margin of the lateral ventricle. We do see a little trail of gray matter heterotopia. So this is actually what's called a transmantle gray matter heterotopia in the setting of a deep sulcus. So this patient has a transmantle heterotopia with a deep sulcus and some areas of polymicrogyria adjacent to it. On the right side, we have a closed lip schizencephaly lined by polymicrogyria. We have several additional areas of gray matter heterotopia, and we have dysgenesis of the anterior and mid portions of the corpus callosum. This is a young child, approximately 1 year of age, who had enlarged ventricles and bilateral schizencephalic clefts. A shunt was placed, so you can see this ventriculostomy catheter that goes into this large CSF space. And we can see a large left-sided open lip schizencephalic cleft, or what looks like that. We can confirm that on MRI when we confirm that it's lined by gray matter. And also a right-sided schizencephalic cleft. Once the shunt was placed, we can see the CSF space decreased in size. There's been decreased mass effect upon the remaining parenchyma of the left frontal lobe and the left occipital lobe. Here's the MRI appearance of the shunt apparatus. And notice that the right-sided schizencephalic cleft, you barely can see CSF going through it. So this now is closer to what people would refer to as a closed lip schizencephaly. You can see in this patient, there's abnormal sulcation lining the margins of the schizencephalic cleft. So it's gray matter with polymicrogyria. If we go to the right side, we also see areas of polymicrogyria. That shows up better on this axial T1 weighted image, where you have polymicrogyria lining this cleft. Now, this also brings about the challenges in pediatric imaging, where due to their small size and due to some movement, even sometimes if they're getting sedated, it can be difficult to get pristine images like you see in a textbook on every single case. But you don't need it. You don't need to prolong sedation in a child to get an image for a textbook, as long as you can make a diagnosis. So if you know what you're looking for, if you make your diagnosis, all you need is images that can help you make your diagnosis. And so this patient has bilateral schizencephaly, a large open lip left-sided schizencephalic cleft, and a very narrow open lip versus closed lip right-sided schizencephalic cleft. This is an MRI in a 3-year-old child with seizures and developmental delay. We can see a lot of aspects of the cerebral hemispheres look normal. But as we go inferiorly, in the posterior aspect of the right temporal lobe and the right occipital lobe, we see a very abnormal appearance of the cortex. We don't see a normal sulcation pattern, and we also don't see normal white matter. At this age, the white matter should be relatively hypointense on T2 weighted imaging, as we see here on the left, but we're not seeing that on the right. On sagittal T1 weighted imaging, we're seeing a very irregular sulcation pattern, some areas of polymicrogyria, but that doesn't tell the whole picture. If we go to a thin section axial T1 weighted image, we see small areas of gray matter heterotopia within the deep white matter. We see gray matter heterotopia along the margins of the lateral ventricle, which is subependymal heterotopia. This here, where it's heterotopia that's not within the subependymal region, but in the white matter, is called subcortical heterotopia. So this patient has multifocal areas of subependymal and subcortical heterotopia, some overlying polymicrogyria involving, as we can see here, is the posterior aspect of the lateral surface of the right temporal lobe, extending posteriorly to the right occipital lobe. This is an MRI of the brain in a 9.5-year-old child with headaches. And at first glance, everything looks normal. In a normal MRI, I look for the size and symmetry of the lateral ventricles. The lateral ventricles look normal size and appropriate morphology and symmetry. Third ventricle, fourth ventricle. At this age, we're seeing near complete to complete myelination, where on T2 weighted imaging, everything looks hypointense for the myelinated white matter. By 9.5 years old, the only white matter which is unmyelinated is very subtle peripheral juxtacortical connections in the frontal lobes, which is typically below the ability to detect on MR imaging. So everything looks fairly normal. It's important when looking at MRI to look at all imaging sequences, one of which is the diffusion-weighted image. And people are used to using diffusion-weighted imaging to look for strokes. And diffusion-weighted imaging is excellent for looking at strokes, excellent for looking for abscess, empyema, things like that. But there's more information provided. We can already see in here, there's a different appearance between the gray matter at the periphery and the white matter. The gray matter looks a little bit brighter, and that's normal, that's expected. Well, we can use that to our favor as we're looking through here. We see a little focus of gray matter right here along the superlateral margin of the body of the left lateral ventricle. If I look at this T2-weighted image, I see a very subtle nodular area of gray matter. If I go back to this sagittal T1-weighted image, I can see a small focus of gray matter, and on the coronal stir, here is the right caudate body, here's the left caudate body. Just superior to that is a small focus of gray matter. So while it otherwise looks like a normal study, the diffusion-weighted image, which normally we don't think about using for things other than stroke or abscess, actually was able to alert us to a very small focus of gray matter heterotopia. This is an MRI of the brain in a child with developmental delay. And if we look on the T2-weighted imaging, we're seeing ill-defined gray-white differentiation posteriorly in the occipital lobes. If I go to the sagittal T1-weighted image, I actually get a little better delineation. I see the cortex at the periphery. Intervening is an area of white matter. The myelinated white matter looks bright on T1-weighted imaging. And then following that, beneath the surface, I'm seeing an additional area of gray matter-like signal. This is band-type heterotopia in the absence of a significant Lissencephaly spectrum disorder. The band heterotopia is seen most pronounced posteriorly in this individual. Anteriorly, here in the frontal lobes, we're seeing gray matter and subjacent white matter without band heterotopia. We're not seeing any significant Lissencephaly appearance. So this is band heterotopia in the absence of Lissencephaly. If we look at this coronal stir image, you can see it a little bit better than the original T2-weighted image. And then one trick you can do is you can actually, on a stir or a T2-weighted image, you can invert from a gray-white perspective. And that sometimes makes it almost look similar to a T1-weighted image. And you can see this band of gray matter going beneath the cortical surface. It's a little more evident than it was without the inversion. This is an MRI scan of the brain in a 5-year-old child with developmental delay. One of the first things we see is there's an abnormal configuration of the lateral ventricles. The body of the lateral ventricles are somewhat parallel, whereas normally they sort of angle laterally as you go posteriorly. So there's a parallel body of both lateral ventricles. As we go inferiorly, the atria and occipital horns of both lateral ventricles are larger than we typically see. This is called colpocephaly. As we go up, we're seeing no intervening corpus callosum. If we go to the sagittal T1-weighted image, for the midline structures, we do not see any aspect of the corpus callosum. Additionally, normally just above the corpus callosum is the cingulate gyrus, which runs anterior and posteriorly. Here, we do not see that. We see these radiating gyri that come all the way down to the third ventricle here. We also see, here's the anterior commissure, which is a little on the small side, but otherwise we're not seeing any commissural fibers of the corpus callosum. If we look on a coronal image, we can see a vertically oriented third ventricle, and there's no intervening corpus callosum. If we go back to this sagittal T1-weighted image, the distal branches of the anterior cerebral artery have a very low position. Normally they would go superior to the corpus callosum and extend as the pericallosal artery. Those have a very low position that we can see right here, nearly as low as the level of the internal cerebral veins. One of the other things we see, in addition to this vertically oriented third ventricle, there's a characteristic configuration of the interface between the third ventricle and the lateral ventricles, which has sometimes been referred to as a Texas Longhorn sign or in some cases like this, may look sort of like Bullwinkle the moose. Along the medial margin of the body of those lateral ventricles, there's a bundle of white matter here. These are the fibers that would have crossed the corpus callosum, but they don't. So they are directed anterior-posteriorly instead of directed laterally to go across the corpus callosum. This area is known as Probst bundles. One other thing we see in this child is there's an increased axial length of both globes. If we look from the anterior aspect of the cornea to the level of the optic nerve insertion, there's sort of some posterior protrusion and an increased axial length. This needs to be further characterized with an ophthalmologic examination and may be indicative of some underlying genetic underpinnings to this disease process. This is an MRI of the brain in a 9-month-old child with developmental delay. And on this sagittal image, there's a few things that we can notice. First of all, we do not see any corpus callosum. But secondly, unlike the prior case of agenesis of the corpus callosum, we're seeing a very high positioning of the superior aspect of the third ventricle. We're seeing cerebrospinal fluid all the way up in the intrahemispheric fissure, which normally you don't see. If we look at this on the axial image, we can see there's a cystic structure associated with the superior aspect of the third ventricle. It's actually displacing some of the vessels here, the distal branches of the anterior cerebral artery, and we can go all the way to the top. We do not see an intervening corpus callosum. Similar to the other case of agenesis of the corpus callosum, we have a parallel configuration of the body of both lateral ventricles. We have enlargement of the atria and occipital horns of both lateral ventricles, known as colpocephaly. On a coronal image, we see the vertically oriented third ventricle with direct continuity with the intrahemispheric fissure. We see an atypical configuration between the third ventricle and the lateral ventricles, sometimes referred to as the Texas Longhorn sign. We see here, on this case, because the patient is young and the white matter is not fully myelinated, we actually, along the medial margin of the body of the parallel lateral ventricles, see an area of dark white matter. This here is very subtle early myelination, resulting in a T2 hypointense appearance within the Probst bundles. The Probst bundles are anterior-posteriorly directed fibers that are the fibers that would have crossed and become commissural fibers crossing the corpus callosum, but they stay here in this location. So these are the Probst bundles. This is a vertically oriented third ventricle with an intrahemispheric cyst. Agenesis of the corpus callosum is often associated with an intrahemispheric cyst. It's unclear if it's truly an arachnoid cyst, or some people have referred to this as cystic meningeal dysplasia related to the abnormal development. Either way, it forms as a cyst and occasionally can enlarge and may require shunting or fenestration. This is an MRI of a 6-year-old child with developmental delay. One of the first things we see on this mid-sagittal T1 weighted image is there's a dysplastic appearance of the corpus callosum. The corpus callosum is foreshortened in the AP dimension. We see the splenium of the corpus callosum, the isthmus, the body, the genu, and the rostrum. We see what looks like all the parts of it, but it's just smaller than we normally expect. The splenium of the corpus callosum should normally go posteriorly to be posterior and superior to the pineal gland right here. The anterior commissure is also small in caliber. If we look on the axial T2 weighted image, we see an irregular configuration of the lateral ventricles. Additionally, on the lateral margin of the body of the left lateral ventricle, we're seeing some areas of irregular gray matter. So this is gray matter heterotopia. So this is a patient that has dysgenesis of the corpus callosum with gray matter heterotopia and an abnormal configuration of the ventricular system. Now, this patient also had seizures, and one of the treatments for seizures, in particular seizures with drop attacks where a patient may fall, is transection of the corpus callosum. So 2 years later, this is a mid-sagittal T1 weighted image after there was surgical transection of the corpus callosum. You can see on the axial image, this is in the early postoperative period, and we can see they've transected the fibers that were once crossing the midline in the corpus callosum. What this allows in a patient with what's called a drop attack, or when they have a seizure, they fall over, this prevents propagation of the seizure to the contralateral cerebral hemisphere, in which case the patient, when they have the episode, they do not lose full control of their body. Half of their body maintains control, so instead of falling over, they still have the ability to maintain some balance and catch themselves. One of the things postoperatively we may do is look at DTI imaging. In particular, this is the directionally encoded fractional anisotropy map. Red is the color of transversely oriented fibers, and we can see there's transection of the transversely oriented fibers in what was previously was the rudimentary corpus callosum in this individual. We can also process that as diffusion tensor fiber tracking, and we can see these fibers go up to the transected margin of the corpus callosum, but they don't cross over. Similar if we do a seed in the contralateral cerebral hemisphere, and we can check different white matter bundles in different portions of the brain, and here we do not see any fibers crossing the corpus callosum. These images with the diffusion tensor fiber tracking are one way to show the epilepsy neurologist and the neurosurgeon postoperatively that there has been complete transection of the commissural fibers traversing the midline in the corpus callosum. This is an MRI of a child who's 5.5 years old with developmental delay. And if we look at the mid-sagittal T1 weighted imaging, we're not seeing what looks like a normal corpus callosum, similar to the patients with the agenesis of the corpus callosum, which we saw before. We have a parallel appearance of the body of the lateral ventricles, and we have mild enlargement of the atria and occipital horns of both lateral ventricles, left greater than right, sort of a milder version of colpocephaly than in some of the other cases that we've seen. Now, this is not a true agenesis of the corpus callosum, because if we look here, we actually see some midline commissural fibers in a portion of the corpus callosum. If we go back to the mid-sagittal image, we see a very, very small area. So this is not complete agenesis of the corpus callosum, which means complete absence, but this is definitely a very severe dysgenesis, or abnormal development of the corpus callosum. In terms of other commissural fibers, we see a small anterior commissure right here. Otherwise, all the other features of agenesis of the corpus callosum seem present. We're seeing a low position of the distal branches of the anterior cerebral artery, which would have been the pericallosal artery. We're seeing absence of a cingulate gyrus. We're seeing these radiating gyri. So normally the perisagittal gyri of a cerebral hemisphere stops at the level of the cingulate gyrus, which goes anterior-posteriorly, whereas here we're not seeing it, and so we have these gyri that radiate all the way out. The corpus callosum would normally be here with the cingulate gyrus above it. Given that that's absent, this area here becomes relevant because we have these gyri that radiate all the way out from the third ventricle, whereas if there was a cingulate gyrus present, that would not be present. On the coronal image, we also see a vertically oriented third ventricle, and a lot of things that look, the configuration looks somewhat similar to the agenesis of the corpus callosum cases, but we actually do see a portion of the corpus callosum in the midline. This dark area here on this STIR image are myelinated fibers in the remaining portion of the corpus callosum. So this is a patient with severe dysgenesis of the corpus callosum, but not complete agenesis. This is an MRI scan in a 7-year-old child with headache, and at the level of the body of the lateral ventricles, there's normal symmetry between both cerebral hemispheres, and everything looks okay. If we go inferiorly, we see this prominent area of bright signal on T2 weighted imaging. If I go anteriorly on the coronal STIR, we also see the anterior aspect of the left middle cranial fossa is filled with fluid, and is also actually, if we look at the transverse dimension of the anterior aspect of the left middle cranial fossa, it's slightly larger than the anterior aspect of the right middle cranial fossa. Enlargement of an area is typically a sign of a chronic process. If we look at FLAIR imaging, we can see that the area that was bright on T2 weighted imaging is dark. This confirms that we have pure fluid signal. On T1 weighted imaging, we can see the posterior margin of this fluid collection, there's brain parenchyma with gray matter. This is important because if there was a prior stroke involving the anterior aspect of the left temporal lobe, then we would not have a margin of gray matter at the interface. The gray matter would have been injured, and you would go straight to white matter. So this is a sign that this is not an acquired injury to the brain. Diffusion-weighted imaging shows that this area has no restricted diffusion. At this point, we can be fairly confident that this finding in the anterior aspect of the left middle cranial fossa is an arachnoid cyst. It is bright on T2-weighted imaging. It shows suppression on FLAIR imaging. It shows absence of diffusion restriction. And we do not see any signs of injury to the subjacent brain. In contrast, if we saw bright signal on diffusion-weighted imaging, that would be suggestive of this being an epidermoid. Diffusion is always important to look at on a suspected arachnoid cyst because an epidermoid cyst can look like an arachnoid cyst on regular imaging. It can be bright on T2-weighted imaging, and it can actually suppress on FLAIR imaging. While there is no signs of injury to the left temporal lobe, the space-occupying aspect of this arachnoid cyst does result in slight hypoplasia of the left temporal pole. It also results in slight bony expansion of the anterior aspect of the cranial fossa. We can see on the right a normal greater sphenoid wing. We can see the contour along the anterior aspect of the middle cranial fossa. On the left side, this is bowed anteriorly. In contrast to the margins of the right greater sphenoid wing, the left looks smaller. That's because there's been bony remodeling from chronic pressure from this arachnoid cyst. This is chronic low pressure, not high pressure. This is important to notice because these findings, if they can confirm an arachnoid cyst, indicate this is an incidental finding. Arachnoid cysts very rarely cause symptoms and very rarely require intervention. This is an MRI scan of the brain in a 2.5-month-old child with severe seizures, predominantly infecting the right side of the body. Immediately we see several abnormalities. First of all, we see an asymmetry in the size of the left hemicranium. We can see here the left hemicranium is larger than the right. The left cerebral hemisphere looks larger than the right. The left lateral ventricle, especially posteriorly, looks larger than the right. Anytime you have a hemispheric asymmetry, the first thing to figure out is whether one side is too big or one side is too small. In most cases, the side that is too small is the abnormal hemisphere. But there's one case where the side that is larger is the abnormal side. And that's this case. This is called Hemimegalencephaly. Hemi meaning half, mega meaning big, and cephaly meaning head or brain. So half of the brain is too big. And we can see several different abnormalities. First of all, posteriorly, we see thickened cortex, which is a featureless surface. So this is a Lissencephaly-like appearance. We're seeing white matter signal abnormalities subjacent to that. We're seeing ipsilateral enlargement of the right lateral ventricle. Now, I mentioned in hemispheric size asymmetry, trying to figure out which side is abnormal. In general, a rule of thumb is the side with the larger ventricle is the abnormal side. So here, even though the left side is abnormal, it also has a bigger ventricle. Now, anteriorly, the brain is not normal either. We have areas where we don't see the sulcation as well, and this is actually a focal area of polymicrogyria in the left middle frontal gyrus. And then if we look at the white matter in the left cerebral hemisphere is darker than the white matter in the right cerebral hemisphere. In hemimegalencephaly, it is not uncommon to have accelerated myelination. Some of these features can be seen on T1-weighted imaging, where you have a subtle, hazy, intermediate bright signal in the white matter, compared to the normally expected hypomyelination at this age seen in the right cerebral hemisphere. So this is likely a sign of accelerated myelination in the abnormal hemisphere in the setting of hemimegalencephaly. One of the things that can be done to treat hemimegalencephaly, given that it is often refractory to medical therapy, is a procedure called a functional hemispherectomy. A functional hemispherectomy has to do with either resection or disconnection of nearly the entirety of the left cerebral hemisphere. We see here on this early postoperative image, there has been resection of the left temporal lobe. There has been resection of the left insular cortex. But the frontal pole and the occipital pole remains present. Instead of removing it, they disconnect. So we see this transection go from the margin of the temporal lobectomy to the posterior aspect of the intrahemispheric fissure. So this posterior cortex remains, but even if a seizure arose from this area, it will not propagate to the rest of the brain because it has been completely disconnected. Similar, the frontal lobe has been disconnected. There's some parenchyma near the vertex also in the left cerebral hemisphere, the posterior frontal lobe as well as the parietal lobe that is present. The way this is disconnected is they do a corpus callosotomy at the time of the procedure. So here we see a transection going in towards the intrahemispheric fissure, and we see the corpus callosum has been transected. So the remaining portions of the left frontal lobe and left occipital lobe, as well as up near the vertex, the left parietal lobe, while they remain present, they do not have the ability to have seizures propagate to the right cerebral hemisphere or the working cerebral hemisphere. There's a few things to be aware of in this. First of all, this procedure of a functional hemispherectomy works well and works best in very young children, often performed by the first year of life. Why is that? Because normally the right cerebral hemisphere controls the left side of the body for motor and sensory, and the left cerebral hemisphere controls the right side of the body. If a functional hemispherectomy takes place prior to full maturation of the brain, it is possible for the right cerebral hemisphere to also retain the ability to control the right side of the body. So therefore, a patient with a functional hemispherectomy will not be hemiparetic. The other issue is language. In a majority of individuals, the left cerebral hemisphere is where language is centered. In this individual where there was left-sided hemimegalencephaly, there was a chance, if the functional hemispherectomy was performed later after development of language, that the patient would have severe impairment. But performing some of these surgeries prior to full maturation of motor and language functions gives the chance for the remaining cerebral hemisphere to take over some of those functions. This is an MRI in a 10-year-old child with headache, and we see an abnormality. We see an area of bright signal in the posterior aspect of the intrahemispheric fissure. And on the sagittal T1 weighted image, we see along the superior aspect of the corpus callosum an area that is bright with adjacent hypointense signal. This sagittal T1 weighted image is performed with a gradient technique. One of the things you can do is actually use a regular spin echo technique, and some of this susceptibility artifact along the edge goes away, and you can see this curvilinear area of T1 shortening, bright signal, that goes along the superior margin of the corpus callosum. You can see the normal portions of the corpus callosum. There's the rostrum, the genu, the body, the isthmus, and the splenium of the corpus callosum. The lipoma follows all the way from the anterior body over the isthmus and splenium and hooks around the splenium. This is likely a lipoma of the corpus callosum, but to confirm what it is, we use fat-suppressed imaging where we keep all other parameters identical, and we see that this bright signal on T1 weighted imaging goes away. This confirms that it's a lipoma, that it's just fat. An intracranial lipoma is often in the midline. Along the superior margin of the corpus callosum is one of the most common places. It's considered to be an incidental finding. One thing to be aware of, as we saw on that gradient T1 weighted image and also on the susceptibility weighted image, you often see susceptibility hypointensity along the margins of the callosal lipoma. That can be totally normal, and that should not dissuade you from this being the diagnosis. This is an MRI of the brain in a 3-year-old child with developmental delay, and there's nice normal appearance of the lateral ventricles, appropriate myelination in both cerebral hemispheres. We're not seeing any issues yet until we get down a little bit lower on the right posterior aspect of the mesencephalon. We see this area of T1 shortening. We don't know for certain what this is yet, but there's a couple things we can do. One of the things people will sometimes do to evaluate a finding is do post-contrast imaging. It's still bright on post-contrast imaging, but on post-contrast imaging, we don't know if this is bright signal from post-contrast enhancement or if it's the intrinsic T1 shortening from this finding to begin with. However, prior to giving contrast, T1 fat-suppressed imaging was performed, and the bright signal went away. That confirms that this is fat, and so therefore it is a lipoma. And similarly, on post-contrast imaging, the post-contrast bright signal that we see here on this post-contrast T1 weighted imaging goes away on post-contrast T1 weighted imaging with fat suppression. So therefore, this finding has bright signal related to fat, which is a small lipoma of the tectal plate, and is not an enhancing lesion. If it did not suppress on fat-suppressed imaging, then you have to wonder about other possible sources of intrinsic T1 shortening. One of the most common ones is subacute blood products, or methemoglobin. In this patient, that small area of bright signal on T1 weighted imaging was originally raised as concern for a hematoma, but appropriate use of fat-suppressed imaging helped confirm that it was not a hematoma. A tectal plate lipoma will often show up at either the 5 o'clock or the 7 o'clock position, and that's exactly where we see it in this individual. So being aware of the normal location for this lipoma, as well as being aware of the MRI techniques you can use to confirm the fatty nature, fat-suppressed imaging, both pre and post-contrast in this case, it allows you to confidently state that this is an incidental lipoma that does not require follow-up and should have no implications to the brain development.